Carb USA 2024 here in San Diego. I have with me Zachary Lott and Dr. Lily Johnston. It was very interesting. I was walking down the hall and I saw a group doing CIMT. You ever heard of that? If you've watched much of our channel, you certainly have. I walked back past them again a little bit later and I heard the name cardio risk. So I went back to talk to them, and it turns out Zachary and Lily already know of my name. They've already seen some of our folks. So Todd, you want to tell us a little bit more about what you do and connection?
Zachary Lott, I'm a nurse practitioner by training. I started Nexus Healthspan about 3.5 years ago now, where we specialize in cardiometabolic disease, lipidology, hormone health, and even treat erectile dysfunction as it's another form of cardiovascular disease.
Could I interrupt?
Yeah.
Did I just call you Todd?
You did. It's okay. We were talking about Todd earlier. He'll appreciate the shout out.
I know. Go ahead.
Yeah, so we've been in business for about 3.5 years and have had some fantastic results with our patients. And we do scans for your office, which has been nice, seeing some of your patients. We do scans for Amy Doneen's office as well, seeing some of her patients. And it's nice to see everyone's results and seeing arterial age reverse and see decrease in cardiovascular disease. And so we do a lot of specialized and advanced testing, whether that be laboratory testing, imaging, CIMT. We started using the Clearly CTA, which is a really neat technology. And Dr. Lily Johnston came on about a little bit earlier this year, and I'll let her introduce herself.
Yeah, so Lily Johnston. I'm a vascular surgeon by training, and I got really disenchanted with treating end-stage disease, and particularly doing amputations for people with horrible metabolic disease who had never been told that this was reversible. So I'm proud to be a founding member of the Society for Metabolic Health Practitioners, and I've been coming to this meeting for a couple of years now, and this was really my entree into the world of so-called lifestyle medicine or lifestyle modification as part of a comprehensive treatment strategy for cardiometabolic disease. You know, I'd love to put myself out of business someday as a surgeon, and really would just be so happy if people never needed a vascular operation ever again because of how morbid they are. So I really have a passion for trying to reverse or at least stabilize severe cardiometabolic disease and atherosclerosis.
You know, there are so many frustrating things about being a physician, so many things where you feel like you're shoveling against a tide. And, you know, there's a fellow, Gooby and Doobie, the neurosurgeon. Have you heard?
I've seen him, yeah. I've seen his talk about why he quit.
Yeah, about why he quit. And I don't think that's the right thing to do. Obviously, I've had a lot of my own frustration, but I could not be happier now doing what I'm doing. And the patient population that I have is just amazing. Probably, I don't know, 20% of our patients come in and they've already lost 30 pounds. And they already know more than most doctors about what really causes heart attack and stroke. So
Go ahead.
Let's talk about something, CIMT and the technology. We interviewed a cardiologist recently and got a little bit of hairy eyeball and said, oh, you're the guy using, what is that stuff? Yeah, CIMT, CIMT. So yes, there's a whole lot of garbage in, garbage out with CIMTs. And unfortunately, the standards committees, most docs that know anything about it that have looked at it have looked at the garbage in, garbage out studies.
Yep.
And they haven't really looked. There was a fellow, I can't remember what his name was. He was a cardiologist, and I can't remember which university he was at. But he wrote a great editorial article, and he said, if you look at the places that know what they're doing, this is an excellent technology.
Yeah.
One of the things that I do, just in terms of patients, is say, arterial age is, you know, it's great, it's easy to wrap your head around, and I show them the nomogram down at the bottom left of Todd's format. But my perspective is the real information, if we already know, as many of them do, that you have plaque.
Yep.
The two questions are, do you have plaque? And if you do, is it soft? And that part's pretty hard to screw up, isn't it?
It is, and I use, I regularly do CIMT tests, but I do point of care ultrasound on every person who comes into my office, every new patient. And considering the data that comes from the Cave study, how predictive just seeing plaque in the carotid arteries or femoral arteries, how much really treatment changing information that gives us at point of care.
Say that again. We had a big.
So how much?
We had a big slam right when you said at point.
At point of care. So how much? Just putting that probe on your neck, and even the drug reps get an ultrasound when they come in my office, and I'm interested in looking at everyone's arteries, because most people don't understand what's actually going on inside their body, and a big problem why a lot of people can even be reluctant to make change is it doesn't hurt. But when we can look on a screen right there and say, hey, this is what we're looking at. This is some soft plaque, and this is something worth doing something about. Because there's a very low threshold for taking action and implementing something that can save someone's life or reverse disease, which is my favorite thing to do. And it's nice to see the IMT values stop changing. But I'm an overachiever. I want to reverse arterial age, which we see on a regular basis.
Yeah. So it's interesting. I don't know if you noticed it when you were talking with Dr. Vega, Jesus. A patient walked up, or it's not one of our patients, but somebody walked up, one of your patients that you had seen very recently today, and said, they just found a whole bunch of soft plaque. And she said, I am so glad I heard about this on your channel. Gave me a big hug. I met the lady for about 5 minutes yesterday, and then she walked off to the latest.
And what I think is really important for this community is, in particular, is this idea that labs, particularly lipid panels, even advanced lipid testing, represent population risk, right? Our knowledge of these data represent population risk, right? Whether it's ApoB, LDL particle counts, however you want to conceptualize that. We've gotten better and better, and yet we know that an ApoB of 90 in me may behave very differently than an ApoB of 90 in you. How do we know whether it's adversely affecting me, right? We know that half of people with a myocardial infarction have a normal lipid level, whether it's LDL-C, LDL-P, whatever you want to say. How do you know whether we should be more aggressive? How do you know whether your treatment is required or not, especially if you have adverse effects with medications, if you don't want to be on medications? We have to look. We can't guess anymore, right? Lipid panels, labs, they're a guess.
Right.
HSCRP, I mean, it's all part of the idea, but what does it look like in you? Is it doing anything in you? And if so, do you want to do something about that? Right? So I think it really helps make that connection for people about what's going on inside. The labs are abstract. They're not concrete. Showing somebody their plaque, particularly if it's soft and vulnerable, is really visceral. It hits home for them. They see it, they understand that, and they can kind of think about that, mull that over, and it helps make treatment decisions. And then it's so rewarding when they see those numbers get better, right? When we see plaques stabilize and become heterogeneous versus soft, when we see the arterial age come down, that's rewarding, and it reinforces all the good habits they're already doing in terms of nutrition, movement, sleep, stress reduction, and it encourages compliance with medications. So I find it's a super valuable tool to motivate patients to own their own care, own their health, take those next steps, and to continue good behaviors when they see progress.
And Lily alluded to this, but it becomes a very, very useful tool to help us individualize treatment plans for each patient. Watching, serial IMTs year over year, if we see that arterial age changing in the wrong direction or too rapidly, then we know we need to step our game up somewhere. And just like she said, labs that look the same in two patients, their arteries are going to respond very, very different for reasons that we can't always account for in the labs. So we use that information to custom tailor a treatment approach to every person that we see. And a lot of the things that have really surprised me is the impact and the role that things just like hormone therapy, for example, where that plays a role in the whole big cardiometabolic disease prevention picture. And it's been a wonderful process along the way, especially using the IMT test. I tell everyone who comes in that I get that ultrasound out for, like, this is my favorite toy in the office, and we're going to learn so much about you within just a couple seconds before we even go through the whole exam protocol.
So speaking of which, did you tell us about your company, about Nexus?
Yeah. So we're in Mission Viejo, California, so South Orange County, California.
Well, I'm from South Carolina.
South Carolina.
So where is that? Where is Mission Viejo?
So we are all the
We're in
way
San
on
Diego
the west
right now.
coast we're in California. So South Orange County, California on the west coast.
How far from San Diego?
It's about an hour and a half north from San Diego,
Okay.
and about an hour south from LA. So right between
Okay.
San Diego and LA.
And I think you said there are 2 cardio-risk certified providers in the whole state, right?
Yep, there's one down in San Diego, and then I'm the other one up in Mission Viejo.
Oh,
and in a
okay.
couple of weeks, she'll be the third. So
Okay,
she's going to
great.
see Todd pretty soon here, and she'll get trained and certified with them. So she'll be number 3 in the state of California. But we have patients that travel as far as from Hawaii, all up the
Oh,
west
yeah.
coast, even 2 patients from Alaska.
Yeah.
Just to come down and get that CIMT test.
Well, they can go to Disney later.
Yeah, absolutely.
Disney is in Orange
They make a whole
County.
vacation out of it, yeah.
You know, I might have 2 of your patients from Hawaii.
I think they are yours.
Yeah, I think they very well might be.
Yep.
So Lily, a minute ago you were talking about population risk factors as opposed to actually seeing disease. You sound like you got some good statistics training, epidemiological training.
I do, and you and I just chatted about this, but I have a master's in public health from the Johns Hopkins Bloomberg School of Public Health, and so I like to, marry my statistical background and my ability to analyze the literature, take a real deep dive in some of this, and it's great at the population level. It's really wonderful to understand what all this science means for us as a group of humans, and I treat individual patients, right? We look at whole person care, and you are not a randomized controlled clinical trial. And just because it worked for 30 out of 100 patients in some trial doesn't mean it's going to work for you. And I really think there's the art of medicine is found in trying to understand how to bring the knowledge that we have from some really excellent science, and in the nutrition space, maybe a little less excellent science, but trying to assimilate that, understand that, and translate that for patients into here's what we know, here's what we think we know, and then here are your options. How does that sound for you? What are your goals? What are your priorities? And what do you think about these options, right?
So at Hopkins we called it denominator medicine.
I love it.
And so you're looking at the whole population. You're looking at a group. Now it's interesting, we talked about aspirin in a recent video, and it's interesting how people screw that up, denominator medicine. Because when the U.S. Preventive Services Task Force said, in the beginning they said, once you reach age 65, you should take a baby aspirin. And then they said, well, what was it, 3 years ago? They said, well, maybe not. Well, like even the medical science reporter for New York Times, who's a physician, totally whiffed it. He said, it's not indicated anymore. Well, he didn't realize that it's indicated for that denominator, that group of patients who have cardiovascular disease.
I had, as a vascular surgeon, I had primary care doctors taking my surgical patients off of aspirin because of that study and their misinterpretation, right? And it just drove us bananas. But I think
How did you deal with that?
well, you do your best to educate and acknowledge that people are trying to do the right thing. They just mean well. But I think this gets to a bigger question about what is primary versus secondary prevention in the cardiometabolic space, right? Because we have used historically this idea of event or no event to distinguish between primary prevention. You don't have the disease, you haven't had an event, versus secondary prevention, you've had a heart attack, you've had a stroke or a mini stroke. But when we have tools now like Clearly or CIMT, we now have this intermediate category of patients who absolutely have disease. We can see it. We can point to your plaque. But they haven't had a heart attack or a stroke. So how do you treat them? Do you really treat them like a primary prevention patient and say, you're good, you don't need anything, you'll be fine, we'll just let that plaque rupture and hope that it, they can suck it out later and put a little stent in there and it'll be fine, right? I don't want that. Keep growing some more plaque, we'll see what happens. So I think that, folks in our space have really glommed onto this idea that those patients are truly secondary prevention patients, and the people who had an event, they're really tertiary prevention, and that needs to change how we think about these interventions like aspirin, like lipid lowering medications, like anti-inflammatory medications, because the studies broke out these populations by primary and secondary prevention, and now we are found in this space where patients that come to see us say, well, my doctor said I didn't need that. I don't have the disease. I haven't had a heart attack or stroke. I don't need these medications. Well, look at the picture. Like, the proof is in that soft plaque pudding. And I, again, everybody makes their own choices. However, I do believe that if we prove that you have the disease, we have the data that says your risk of an event is high, it's real. And, our obligation is to inform people of those risks and what their options are to deal with them.
So, speaking of that, in a related topic, most people still treat LDL with statins.
I love this conversation.
And it was, it's folks in the Bale-Deneen community have said for a long time, if you don't have plaque, you don't need a statin. And it was 4 years ago, the American Heart Association Standards Committee finally arrived. They said, oh, you know what? If you have a negative calcium score, you don't need a statin.
Yeah.
Uh-oh, they screwed up yet again.
Yeah.
They took one step forward and 2 steps back. And that's a big deal for you guys. Where does that...
So this is something I get really
that?
passionate about.
I'm sure you do.
I love lipids. I get really nerdy about lipidology. And the things that we've learned is LDL cholesterol is a meaningless metric in the big picture of things. We get a lot more meaningfulness from an LDL particle number, but nothing beats ApoB. And if anyone checks 2 labs from a lipid standpoint, they have to know their Lp(a) value and they have to know their ApoB. And those are the things that help me guide therapy. And the discussion about a calcium score, and especially a 0 calcium score, I get really excited talking about this because medicine commonly ignores a great big blind spot in that test. And you know what it is. It's
That's
soft
exactly
plaque.
where I was going.
It doesn't see soft plaque. And that's the value that I love about the ultrasound is right away I know. And I can't tell you how many patients I've had. It's usually someone in their 40s, 50s who said, I just got a calcium score and it's 0. And my cardiologist said, I'm in the lowest risk for the next 10 years. And I said, well,
And by the way, I don't need my baby aspirin.
Yeah, exactly. And so I get
Or
that
my
ultrasound
statin.
on them. Yep. And if we see that soft plaque, then we know you went from a low risk up to a much higher risk category. And
And they just the calcium score totally missed the soft plaque because the technology's not going to pick it up.
yeah, it's X-ray.
And I think we have to acknowledge that yes, a 0 CAC, even if you have soft plaque, does predict a low risk of events in the next 10 years. That doesn't mean you don't have disease that we should treat. So I think it's important to understand where the critics come at us because they're not entirely wrong. The event rate, if your score is 0, is lower. I get it. And I hear about primary prevention, especially in women, right? I'm passionate about women's cardiovascular disease, and in primary prevention in women, statin therapy doesn't work as well in the old data. I get that too. So I have a little bit more nuance and appreciation about this conversation. A lot of the patients from especially this low carb community have heard a lot of stories about statin therapy, and some of that is true and correct, and some of it is true, correct, and not applicable to them. And so it becomes a super nuanced conversation, and individualized treatment is always where we start and end the day. And I do believe that it's a good therapy for a lot of people, especially if you have disease, and we have alternatives if that is not something you want to do, right? We have lots of things we can use, lots of levers we can pull to address cardiometabolic risk. Lipid lowering, ApoB lowering is just but one.
I just had a long conversation with Rob Sybos, who's totally anti-statin, and so I'm a bit worn out on that discussion. It is very nuanced. Like the Bale-Deneen community, I don't treat LDL levels unless a patient really wants to, and I'm not that paternalistic. My patients know more about this issue than most docs, as in 90+% of docs. And when I do recommend them, it's only for proven plaque and for low dose. Very low dose.
Pleiotropic effects, inflammation reduction, right? ApoB lowering is a nice bonus, and yes, there are some data to support doing that in patients with plaque and disease, but we know that this is a complicated picture, and I also hear, yes, at high doses, statins may increase insulin resistance. I hear that, right? I hear that it's different in men and women. That may have something to do with how we've done those studies over time, and I hear all that too. But I think, patients who are informed can also be in an echo chamber, right? This community in particular is fairly anti-statin, and then you listen to Peter
so,
Attia, and
boy, do I get beat up.
he wants it in the drinking water. So I think, as providers, it's important we don't put ourselves in that echo chamber, right? Our job is to get multiple perspectives, and reasonable people will disagree. That's okay. But it's my job, I perceive my job to be here, to hear, learn, challenge my own perspective, and make sure that I'm doing the best and learning as much as I can. So I try to hear David Diamond and Rob Sivas and all these people who tell me statins are evil and they should never be prescribed. And then I go listen to Tom Dayspring and Peter Attia and hear all about how it should be in the drinking water, everybody should be on it, ApoB should be in the toilet for everybody as much as possible, right?
And if you're like me, you don't agree with either side.
I don't. I absolutely don't. And so we can be friends, Tom.
So I thought one of you was going to go down that path of the study that was done on people with a 0 calcium score and reported risk of heart attack. I don't. You guys haven't seen that study?
I don't recall off the top of my head, no.
It was about 3 years ago. We got to go find it. I did a video on it,
Okay.
and it underlined the point that the three of us know. What you brought up, a 0 calcium score does not mean that you do not have soft plaque. And so those of us who understand plaque at that level always worried about that. And sure enough, these folks did see it. It was a low risk, as you pointed out, Lily, but it was a risk. And we were missing the current standard. On the one hand, which doctor actually knows that the standards committee for the AHA doesn't recommend statins if you've got a 0 calcium score? They don't know it anyway, so that's not really a practical consideration. It's more of a theoretical one. But even then, beyond that, who knows that? Who's aware that yes, there is a remote risk,
Well, and again,
and it
this
was
is
demonstrated.
how old were you when you had your scan done, right? Do you have 2 scans that are 0? What's your trajectory over time? I think people misunderstand the idea if you get a 0 score at 40, I'm good forever, right? I'm great. These tests were never intended to be done in isolation. Now, is it my choice for a test? Absolutely not. Of course, I would prefer something that will image soft plaque, whether that is coronary CT angiography or CIMT in our practice, of course. But if you come to me with a coronary calcium score, we'll talk about it, we'll use it, especially if it's non-zero. That's very illuminating. But if it's 0, again, if you're 80 and your score is 0, that means way more to me than if you are 40 and your score is 0. If you're diabetic and your score is 0, right? We have all kinds of, 0 doesn't mean 0 in everybody. It's nuanced again, and so we have to take all that context into account when we think about these tests.
Well, as you know, Jesus is the channel manager, and he's been managing the camera most times, and stays, as we discussed, he stays behind the camera and laughs at me as I make a fool of myself. But I'm going to pull you in, Jesus, about something you found out about these people with calcium scores over 2,000.
You read my mind.
Okay.
And I'm gonna do a selfie, like if we're taking a picture. What about that?
Oh, well,
Let's see. If I do my phone. Hey.
Hey.
Join us.
okay, here we go.
So, now basically what we found on that study is there's a study over there. People over 1,000 calcium score actually didn't have more risk than those with calcium score of less than 1,000. So, meaning more calcium, more stable plaque.
Right.
And everybody thought higher cardiovascular risk. It was completely the opposite.
Yeah.
So just to bring that out, we covered that on the show. We might
did.
cover that again.
And I think part of the point is, we see these kind of folks all the time. One of the major reasons for people coming to see us is, I got a positive calcium score, and none of my docs know it. But then there's this subgroup that comes in and I've got 1,000 or 1,500 calcium score. I'm drawing up my will and I'm getting ready to die. And more often than not, these are people that have started low carb a year ago, lost 35 pounds, and they're calcifying all of that soft plaque. And to me, I think that's what that study represented more than anything else.
So let me ask you that. I'm going to turn the table a little bit and ask you, because we talk about this a lot, and you just alluded to it, but I'm going to pin you down and make you say it more explicitly.
Okay.
When people talk about progression in calcium scans, right? We talk about going from a score of 300 to a score of 600 over a couple of years. They did the right thing, they measured it again. The epidemiologic studies originally showed that progression in CAC meant progression in risk. But we have Baldanine that says progression in CAC is successful treatment. That is stabilization from soft plaque to calcified plaque. Personally, I wonder if we have conflated some people who have stabilization with people who truly have progression of disease because they have been insufficiently managed, and so it looks overall like progression of risk when CAC goes up. But what do you tell patients when their CAC goes up and they're on best medical therapy as determined by you or somebody else in this, cardiometabolic space?
So if I'm gonna give you some nonverbals. It's a challenge. It is a challenge to talk with these folks, because one of the things that happens is folks will come to see us because of a positive calcium score. They will get going, they'll again lose 35 pounds, and then go get another calcium score expecting to do a victory lap. And when somebody's lost 35 pounds, their fractionation is great now, or it's improved dramatically. Their OGTT has dropped, their insulin response has improved dramatically. To me, it's like I'm seeing every indicator that you're doing the right thing, and you're seeing it too. You don't have to listen to a doctor tell you what he thinks. Your metabolism's telling you this. So why are you concerned? And you also know, we've talked about this, and I've actually warned you, don't go get another calcium score. It's likely to go up. So I get those cases far more than the person who happens to get an increase in calcium score and they're not doing the right stuff. But you're right, everything is, back at Hopkins we learned a thing about conditional probability. And those are the conditions. If your lifestyle and your metabolism are doing the right things, the probability of an increased calcium score being an increased risk is very, very low.
Right, but when we have these denominator medicine studies where we've taken the entire population of people with cardiac disease who we know don't necessarily get optimally managed for their hypertension, they don't get optimally managed for their insulin resistance, they get put on an aspirin and a statin, maybe they take it, maybe they don't necessarily get targeted therapy to any laboratory values, they just get put on these medicines, and then we survey them again.
And they're way more than they do.
Yeah, we put them on high dose statins, so they actually do have some progression in insulin resistance, which doesn't help things over time. And then we, survey them again in 5 years, and they have progression in their CAC. Well, I'm not surprised that represents an increase in risk for that population.
Yeah.
But it's apples and oranges.
I have a good case study that really illustrates this point well. So I had this gentleman, he was referred to me by his PCP as a difficult to treat lipid case. And he came in with an LDL cholesterol in the 40s, and they weren't sure what to do. So we looked at his ApoB and his particle number, and his particle number was about 1,400 with a high small particle count as well. And so we went down the optimal medical therapy route. He had recently had a calcium score at age 44. His calcium score is about 400. 3 years down the road, after seeing some regression in his IMT and some significant improvements in labs in multiple different parameters, at some point along the way, he was sent initially for an angiogram which showed multiple vessel disease with stenosis of 50% or more in multiple different vessels. 3 years later, at age 47, he was sent for another calcium score. It went up to about 1,200. And he was sent for a repeat angio, which showed all those areas of 50% or more were down to 30% or less.
Improved.
So we see
how was that interpreted?
Yeah, so I knew exactly what we were looking at.
You knew what you were
and
looking
his
at.
interventional cardiologist, while he was on the table, said, "Hey, whatever you're doing is working. Keep doing it." But a lot of people will see that increase
when he was already on the table.
Yeah.
Yeah.
But a lot of people will see that increase and a big red flag will go up. I look at that as a healing process. And
Of course.
I had a cardiology colleague tell me one time, a little dirty secret he would use sometimes if someone's not taking their medication, he'd send them for a repeat calcium score, knowing it's going to go up.
Yeah.
Say, see, look, your score got worse. You got to take these meds.
So you went to one of my favorite topics. I'm going to change the camera real quick.
Yeah.
We have discussed healthy calcification versus unhealthy calcification. And that's exactly what Dr. Lilly mentioned. And we discussed that on our rant yesterday. It's very different.
Yesterday, I don't remember.
Well, I'm not surprised, all those statins that you're taking. So we discussed if you have a plaque with a bunch of inflammation, you can develop some calcification that we call spotty calcification. So some healing here and there, but it's not going to be enough. Versus getting rid of that inflammation, your lifestyle, your exercise, dealing with insulin resistance, thyroid issues, autoimmune diseases, all those other conditions that are involved. And then you allow your body to heal through that calcium. It's not islands anymore, not spotty calcification, but just a good layer of calcium that is going to stabilize that plaque.
Yeah.
Very different, and both can give you a high calcium score. So what we do is, my calcium score went up, let's get you a CIMT or CT angiogram.
Yeah.
That allows you to see if you have soft plaque or not.
Yeah.
Then you can know if it's actually higher risk or not.
Right.
So I love to say that all the time. Sorry, Dr. Brewer.
I told you he was smarter than me. So, Jesus, any comments, questions coming from the viewers?
No, I just wanted to say you're my favorite people in this conference so far. So,
We'll take it.
We'll take it.
They're great.
all right.
So, great. Thank you so much. It was great meeting you.
Yeah, appreciate chatting with you.
Thank you so much for the